Ziprasidone in bipolar disorder, QTC monitoring and clinical management. Bipolar disorder affects 2.8% of adults globally, with significant cardiovascular comorbidity. Ziprasidone, a second-generation antipsychotic, exerts antagonism at dopamine D2 and serotonin 5-HT2A receptors, contributing to mood stabilization. Diagnosis requires DSM-5-TR criteria, including at least one manic or hypomanic episode. Management includes ziprasidone 20 to 80 mg/day with baseline and periodic ECG monitoring due to QTC prolongation risk of 0.4 to 2.0%. Key points. Note: ziprasidone increases QTC interval by a mean of 10 to 15 milliseconds compared to placebo, with a dose-dependent risk of QTC greater than 500 milliseconds in 0.4 to 2.0% of patients. Recommended starting dose of ziprasidone is 20 mg orally twice daily, with maximum dose of 80 mg per day in bipolar disorder. Baseline 12-lead ECG is required before initiating ziprasidone, with QTCF, Friedreichia corrected, greater than 450 milliseconds in males or greater than 470 milliseconds in females considered a relative contraindication per FDA guidelines. QTC prolongation risk with ziprasidone is 3.5-fold higher than with placebo, or 3.5, 95% CI 1.8 to 6.7, based on pooled clinical trial data. Ziprasidone is contraindicated in patients with known congenital long QT syndrome. Prevalence 1:2,500, 1:5,000 live births. In acute mania, ziprasidone demonstrates a response rate greater than or equal to 50% reduction in YMRS score of 54% versus 36% with placebo, NNT equals 5.6 over 3 weeks. Food increases ziprasidone bioavailability by 57%. It must be administered with at least 500 kilocalories per FDA labeling. Concomitant use of ziprasidone with other QTC prolonging drugs, e.g., ciprofloxacin, ondansetron, increases arrhythmia risk by 2.8-fold, AHA 2022. Ziprasidone is pregnancy category C. Neonatal withdrawal occurs in 12 to 18% of infants exposed in third trimester. In elderly patients with dementia-related psychosis, ziprasidone increases mortality risk by 1.8-fold, FDA black box warning. Hepatic impairment, Child-Pugh class B or C, requires avoidance of ziprasidone due to lack of dosing data and increased exposure by 100 to 150%. Ziprasidone has a lower metabolic risk profile than olanzapine, with weight gain greater than 7% baseline in only 5% versus 27%, KD bipolar trial. Overview and epidemiology. Bipolar disorder, ICD-10, F31, is a chronic psychiatric illness characterized by recurrent episodes of mania, hypomania, and depression, affecting approximately 46 million people worldwide. Global prevalence 0.6%, 95% CI 0.4 to 0.8, according to the World Health Organization, WHO, 2023 Global Burden of Disease Study. The 12-month prevalence in high-income countries is higher at 2.8%, 95% CI 2.5 to 3.1, with lifetime prevalence of 1 to 1.5% in the United States, NIM, 2022. The disorder affects males and females equally, male-female ratio 1.0 to 1.1, with a median age of onset at 25 years, IQR 18 to 35. Early onset bipolar disorder, before age 18, occurs in 15 to 20% of cases and is associated with more severe illness course. Ethnic disparities exist. Non-Hispanic Black individuals have a 1.4-fold higher incidence, RR 1.4, 95% CI 1.2 to 1.7, compared to non-Hispanic white individuals, while Asian populations report lower prevalence, 0.3 to 0.5%. Socioeconomic factors, including low income, less than $20,000 per year, or 2.1, 95% CI 1.6 to 2.8, and unemployment, or 3.0, 95% CI 2.4 to 3.7, are significant modifiable risk factors. Non-modifiable risk factors include family history, first-degree relative increases risk 8 to 10-fold, RR 8.5, 95% CI 6.3 to 11.4, early childhood trauma, or 3.2, 95% CI 2.5 to 4.1, and specific genetic polymorphisms, e.g., CACNA1 CRS 1006737, or 1.32, 95% CI 1.18 to 1.48. Pathophysiology. Bipolar disorder involves dysregulation of monoaminergic neurotransmission, neuroplasticity, circadian rhythms, and inflammatory pathways. At the molecular level, ziprasidone acts primarily as a high-affinity antagonist at dopamine D2, key equals 4.8 nm, and serotonin 5-HT2A, key equals 0.4 nm receptors, with partial agonist activity at 5-HT1A, key equals 9.8 nm, and antagonist effects at 5-HT2C, 5-HT3, and alpha-1 adrenergic receptors. This multimodal action contributes to mood stabilization by reducing dopaminergic hyperactivity in mesolimbic pathways during mania while enhancing prefrontal cortical serotonin transmission. Genetic studies implicate variants in ion channel genes, particularly KCNH2, encoding HERG potassium channel, which is responsible for the rapid delayed rectifier potassium current, IKR. Ziprasidone blocks IKR with an IC50 of 39 nm, leading to prolonged ventricular repolarization and QTC interval prolongation. The HERG channel is highly sensitive to drug-induced blockade due to its large central cavity and aromatic residues, Tier 652, Phe 656, that facilitate high-affinity binding of lipophilic cations like ziprasidone. Clinical presentation. The classic presentation of bipolar I disorder includes discrete episodes of mania, defined by DSM-5-TR as greater than or equal to 1 week of abnormally elevated, expansive, or irritable mood with greater than or equal to 3 of the following: inflated self-esteem, 85% of cases, decreased need for sleep, 78%, pressured speech, 72%, flight of ideas, 68%, distractibility, 65%, increased goal-directed activity, 60%, or excessive involvement in risky activities, 58%. The Young Mania Rating Scale, YMS, is used to quantify severity: mild, 15 to 19, moderate, 20 to 29, severe, greater than or equal to 30. In bipolar depression, core symptoms include depressed mood, 92%, anhedonia, 88%, fatigue, 85%, insomnia, 75%, and suicidal ideation, 50%. Mixed features: depression with greater than or equal to 3 manic symptoms, occur in 20 to 40% of depressive episodes and are associated with higher suicide risk, or 3.4, 95% CI 2.1 to 5.5. Key points: QTC greater than 500 milliseconds on ECG, risk of TDP increases 3.2-fold. Temperature greater than 38.5 degrees Celsius, suggests neuroleptic malignant syndrome. CPK greater than 1000 U/L, indicating rhabdomyolysis. GCS less than 13, suggests delirium or catatonia. Diagnosis. Diagnosis follows DSM-5-TR criteria. Bipolar I disorder requires greater than or equal to 1 manic episode, duration greater than or equal to 7 days or requiring hospitalization, with or without depressive episodes. Bipolar II disorder requires greater than or equal to 1 hypomanic episode, greater than or equal to 4 days, and greater than or equal to 1 major depressive episode. Mania must cause marked impairment or require hospitalization, and not be attributable to substances or medical conditions. The diagnostic algorithm begins with clinical interview using structured tools. 1. Mood Disorder Questionnaire, MDQ greater than or equal to 7 yes to Part 1, with greater than or equal to 1 yes to Part 2, has sensitivity 67%, specificity 93% for bipolar I-2. Hypomania Checklist 32, HCL 32 greater than or equal to 14 items endorsed, sensitivity 80%, specificity 72% for bipolar 2. Key points: CBC, rule out anemia or infection, HB less than 12 g/dl in women, less than 13 g/dl in men. BMP, Na plus less than 135 millimoles per liter suggests SIAD from psychotropics. K plus less than 3.5 millimoles per liter increases arrhythmia risk. LFTs, AST/ALT 3 times ULN, ULN equals 40 U/L, contraindicates hepatotoxic agents. TSH, hypothyroidism, TSH greater than 4.5 μ/L, mimics depression, hyperthyroidism, TSH less than 0.4 μ/L, mimics mania. Management and treatment. For acute mania, immediate stabilization includes Ziprasidone, Geodon. Key points: secure environment, 1:1 observation if suicidal. Monitor vital signs Q4H, target HR 60 to 100 BPM, BP 140/90 mmHg. ECG within 1 hour of starting Ziprasidone or if arrhythmia suspected. Labs, BMP Mg2+, target greater than 1.8 mg per deciliter, K+, greater than 4.0 millimoles per liter, to reduce arrhythmia risk. References. 1. Mello et al. An updated safety review of the relationship between atypical antipsychotic drugs, the QTC interval and torsades de pointe as implications for clinical use. Expert opinion on drug safety. 2024, 23, 9/11/27-1134. PMID 39126643. https://pubmed.ncbi.nlm.nih.gov/39126643. doi 10.1080/147403338.2024.2392002. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.